Hello and welcome to Echo Asthma Bootcamp. Today we're going to talk about biologic treatment options for severe asthma. I'm Ashley. We're joined by Dr. Sucharita Kher, Hewan, and Rachel, part of my team. And we're just going to get started with our polling questions as always. All right. Thanks everyone for answering those. So now we're going to get started with our presentation by Dr. Kher.
So welcome everybody to today's Echo Asthma program, session 4 on biologic treatment options for severe asthma. My name is Dr. Sucharita R. I'm an assistant professor at Tufts University School of Medicine and an adult pulmonologist at Tufts Medical Center. And I look forward to spending the next hour with you talking about some of the exciting biologic treatment options we've had in severe asthma. So starting with the GINA guidelines, we've reviewed these before. GINA guidelines do not necessarily specify which exact drug to use, but really provide us with guideline to help selection of a treatment for a particular individual patient. And that really depends on the patient's own disease characteristics, their preferences, what phenotype of asthma they may have, what their functional ability is to perhaps use a medication, and then to overall consider the complexity of the medical regimen. The biologics in asthma are among the step 5, the rightmost on the GINA guideline. So there are 5 approved biologics currently in the United States. Omalizumab, which is an anti-IgE monoclonal antibody, is the oldest. We've had about 18 years of experience with this drug. Mepolizumab was then approved many years later and is an anti-IL-5 monoclonal antibody. Reslizumab, which is an IV formulation, again an anti-IL-5 treatment option. Benralizumab is an anti-IL-5 but really works against the receptor rather than the IL-5 molecule itself. And then the most recent kid on the block is dupilumab, which works against the anti-alpha subunit of interleukin-4 receptor. The most important thing about these drugs is that while they do significantly improve exacerbations or decrease exacerbations, improve lung function, and reduce the amount of oral corticosteroids that a patient is exposed to, it's really important to remember that these are add-on treatments. That means that it is only used for patients who have uncontrolled asthma despite the regular use of a combination of medium to high dose inhaled glucocorticoid and a long-acting bronchodilator, and people who have impaired lung function. So it's really for those patients who cannot be maintained despite step 4 GINA guidelines. A little bit more about these approved biologics. All except for reslizumab are subcutaneous by route. Reslizumab is the only one that's IV. Some of these, omalizumab and mepolizumab particularly, are also approved for ages over 6. So for a pediatric population, this table highlights what the patient selection is, and we'll talk a little bit more about each of these drugs in detail and what the evidence is behind using these drugs. And then I really want to use this table to highlight some of the adverse effects. So for omalizumab, which is an anti-IgE treatment, anaphylaxis is about 0.2% of patients. While the risk is really low, it is recommended that the patient carry and know how to use an epinephrine injection with them at all times. The risk of this anaphylaxis is highest initially when they initially get the drug, but certainly has been reported up to 7 days out. Patients also complain sometimes of local reaction at the injection site. For mepolizumab, in some of the studies, patients have had zoster. It's rare, again, less than 1%. And the guidelines typically say to consider a vaccine against zoster if medically appropriate. It's important to note that some of these vaccines are live, and so if the patient is at risk for disseminated zoster, for example, if they're on high-dose steroids or on immunosuppression, it may not necessarily be feasible to give them a shingles vaccine. Headaches are quite common, but can be dealt with some Tylenol, and local reaction can be a possibility as well. For reslizumab, interestingly, one of the side effects is oropharyngeal pain. Anaphylaxis has also been described. Again, it's 0.3%, so it's a low risk. However, is a real risk and is associated with a boxed warning for the drug. For benralizumab, This is indicated predominantly, again, for eosinophilic asthma, and some of the side effects include headache, pharyngitis, and a hypersensitivity reaction. And for dupilumab, finally, injection site reactions are common in about 15%. Hypersensitivity can be noted, and this can present as urticaria, other rashes, evidence of serum sickness. Paradoxically, these patients can also have eosinophilia, and it has been attributed in about 4% of patients who receive dupilumab, as well as the presence of some vasculitis. Ocular symptoms should be looked for when patient is on dupilumab, as these patients can often develop conjunctivitis or keratitis. And I'd like to highlight that for all of these drugs, because it's meant to be an anti-eosinophilic inflammatory drug, it's really important to take a detailed helminth infection exposure history, particularly about travel or if they've ever had a helminth infection in the past. And it's important to treat that helminth infection before starting any of these drugs. So let's go through each of these drugs individually. So omalizumab was approved back in 2003. So as you know, we have many years of data and really good data to support this drug. It has been used for patients who have moderate to severe asthma with a positive skin allergy test, and those who've been poorly controlled otherwise on an inhaled corticosteroid. The dosing for the drug really depends on what the patient's weight is, as well as what the IgE level is and the age. Typically, though, depending on these levels, a dose comes to somewhere between every 2 to 4 weeks. It's a subcutaneous injection. And the data really supports the use of the drug. Cochrane analysis a few years ago of 25 studies showed that it significantly reduced the exacerbation. And overall, there was an absolute reduction in exacerbation compared to placebo, where it was 26%, down to omalizumab, where it was 16% exacerbations. It also has shown to reduce the risk of hospitalization, the significant absolute reduction in the risk, as well as a decrease in the risk in the utilization of inhaled corticosteroids, but not necessarily oral corticosteroids. Overall, in this Cochrane analysis, it was shown that omalizumab was associated with less adverse reaction compared to placebo, except for the local injection site reactions, which were higher, about 9% in omalizumab compared to 5% in placebo. Again, there is a risk of anaphylaxis. People have to carry the epinephrine injection with them, and it's up to us as healthcare providers and nurses to educate the patient about the use of it and the need to carry it with them, particularly around the time that they're getting the injection. The next is mepolizumab. This was approved by the FDA in 2015 as an add-on therapy for severe asthma in kids 6 and over with an eosinophilic phenotype. Of note, an auto-injector is available for this drug. However, it's approved for ages 12 and above. It's a standard dose of 100 milligrams administered subcutaneously every 4 weeks. And there are really 3 pivotal studies that led to the approval by the FDA. First is the DREAM study that enrolled over 600 patients with severe asthma and tested 3 different doses, 75, 250, and 750 milligrams. And this study really showed that mepolizumab cut down exacerbations by 50% at all doses with an excellent safety profile. The MENSA study following the DREAM study recruited 576 severe asthma patients, gave them both IV as well as a subcutaneous dose and compared that to placebo. And both IV and subcutaneous cut down the exacerbations by 50%. Not only this, it also showed improved lung function as measured by FEV1 and improved ACQ scores or symptoms of asthma. And then finally, a study of 135 patients published in the New England Journal of Medicine that recruited patients with severe asthma showed that mepolizumab cut down oral corticosteroid dose by 50%, 32% decrease in exacerbations, as well as a better ACQ score. The next is reslizumab. This is an anti-IL-5 drug approved by the FDA in 2016. It's an add-on therapy for patients with severe asthma, mainly for adults 18 and over with an eosinophil phenotype. Because it's an IV drug, it takes a little bit longer to administer, and it's given by an infusion every 4 weeks with a dose of 3 milligrams per kg over 20 to 50 minutes. There is a 0.3% risk of anaphylaxis with this drug. And there are 3, again, pivotal studies that I'd like to highlight here. The first one is 2 randomized controlled trials that recruited about 953 patients with severe asthma or with eosinophils over 400. This study showed that rosalizumab cut down exacerbations by over 50%, and they had similar worsening of asthma symptoms in both rosalizumab and the placebo group. A randomized controlled trial that recruited 325 severe asthma patients compared two different doses, and this study showed that the lung function is measured by FEV1 as well as symptom questionnaires as measured by ACQ, and the AQLQ did better in the drug or the rosalizumab group compared to the placebo group, and that the higher dose, the 3 milligram per kilogram dose, did better than the lower dose. And finally, a third randomized controlled trial in chest back in 2016 recruited about 490 patients with a 4:1 randomized design, used the dose 3 milligrams per kg. And it's interesting to note that the positive effects, the benefits of rosalizumab in this population was seen only for people who had an eosinophil count over 400. And hence, that's when we consider using this drug, is when people have eosinophil counts over 400. Particularly important to note that in this study, that folks who had EOS below 400 did not benefit as much. The fourth drug is benralizumab. This is an anti-IL-5 receptor antagonist approved more recently in 2017 for ages 12 and above with severe asthma with eosinophilic phenotype. The dose, again, is a standard dose, 30 milligrams subcutaneously. The important thing here to note is that for the first 3 doses, it's administered every 4 weeks, and then thereafter, there's flexibility to administer it every 8 weeks. There is also an option for self-injection here with a pre-filled auto-injector that was more recently approved in 2019. And again, the pivotal studies that showed, the first one was a randomized trial that showed that benralizumab cut down annual exacerbations rates significantly in these patients. This study looked at every 4-week administration as well as every 8-week administration, and both did better compared to the placebo. In addition, lung function was better as measured by FEV1 as well as the symptom score. Long-term data from the above study and aggregate data of over 1,100 patients showed that 75% of these patients had a decrease in more than 50% dose of oral corticosteroids after about 84 weeks of treatment, and 39% of patients identified a more than 90% decrease in the steroid use. So it really helps cutting down steroid use and exacerbations in these patients, in addition to improving lung function and symptoms. And the most recent drug is dupilumab. It was approved in 2018 for ages 12 and above for patients with severe asthma. It's an anti-IL-4 receptor alpha monoclonal antibody that further blocks the downward signaling both of interleukin-4 and interleukin-13. It's approved for 2 different doses. We also have some long-term data for this because it has previously been approved for another indication for atopic dermatitis, and more recently for asthma. Both doses are self-administered, they're subcutaneous administered. The first dose is 400 milligrams for the first dose, followed by 200 milligrams every 2 weeks. And then if the patient has oral corticosteroid dependent asthma, then it's recommended that a higher dose be used. This is 600 milligrams for the first dose and then 300 milligrams every 2 weeks thereafter. Home administration is possible. And there are pivotal studies that show that it cuts down exacerbations by 47% in patients who were treated every 2 weeks, associated with improved lung function. And another study of 200 patients showed that it cut down the dose of oral corticosteroids by 70% in the drug group or the dupilumab group compared to only about 42% in the placebo group. And 80% of dupilumab patients had at least a 50% steroid dose reduction and a 59% lower exacerbation in the dupilumab group. So really tremendous amount of data with all of these drugs. Now, while there are 5 approved drugs by the FDA for patients with severe asthma, I'd like to mention at least one, tezepelumab, which is currently in development, and these are the results of the phase 2 trial that came out a couple of years ago in the New England Journal of Medicine. Tezepelumab is an antibody that is directed against the thymic stromal lymphopoietin, or TSLP, which, if you remember, is pretty upstream on that graph that we discussed last time in the inflammatory pathway. And this study is called the Pathways trial. It's a phase 2 randomized, double-blind, placebo-controlled trial of tezepelumab in patients with a poorly controlled, moderate to severe asthma despite medium to high doses of inhaled steroids. And they recruited over 580 patients that were randomized to either placebo, which are the gray bars, or the colored bars, which are different doses of tezepelumab. And what you could see is that there was significant reduction in the annualized rate of asthma exacerbation in the 3 doses compared to placebo. Most of these p-values are just statistically significant with the exception of a couple. I think the most important take home from this, although it's a phase 2 study, the importance here is that the drug decreased severe asthma exacerbations independent of their type 2 status. So one thing to highlight is all the 5 drugs that we have so far that are FDA approved have been approved for type 2 asthma. We do not have any FDA approved drug for non-type 2 asthma. So this is really exciting that this drug has potential for helping our patients who have non-type 2 asthma, who really don't have much with the exception of our standard inhalers at this current time. And it's one of the reasons that the drug was fast-tracked by the FDA in 2019, and more to come about this in the future. I'd like to also briefly mention the role of bronchial thermoplasty. This is rarely done, but I think it's important for us to talk about it. It involves 3 bronchoscopic sessions that leads to radiofrequency ablation or heat wave application to the airway smooth muscle. As you know, the smooth muscle in asthma plays a very important role in bronchoconstriction. And so this applies radiofrequency ablation to the smooth muscle in the airway. The effects have been studied in the short term, unfortunately, because of the bronchoscopy and the airway irritation, it actually leads to increase in asthma exacerbations. There was also a large placebo effect noted in these clinical studies. Long term, however, it has been shown to reduce exacerbations as well as improve symptoms in the following year. There's no clear evidence, however, to guide patient selection as to who's going to benefit, who's not going to benefit. And so the current utilization is really restricted to clinical trials or registry uses. So I'd be really amiss if I didn't talk about COVID-19 and what to do with these biologics in our current pandemic climate. There is a paper that was recently published where a group of experts across the world really got together to discuss what to do with patients who are already on biologics in the pandemic or if they get COVID-19 infection. And so these are some of the highlights from that paper. Again, I have to preface this by saying there's not a lot of data to support it, but these seems to be reasonable conclusions. First, in the absence of data that would indicate any potential harm, continuing the administration of biologics during a pandemic in patients in whom such treatment is clearly indicated and has been effective. Second, in prior studies, no risk of increased infection susceptibility or immune suppression effect has been reported to date. In fact, omalizumab had a possible anti-infectious effect, and hence they recommend no need to discontinue the drugs during a pandemic. And until more information is available, patients with severe asthma plus comorbidities infected with the SARS-CoV-2, decision for maintaining or postponing biologics until patient recovers should really be done on a case-by-case basis, supported by a multidisciplinary team. Our experience here in my institution is that we've continued people on biologics and they've done well. Some patients, we've actually transitioned them to home administration to avoid having them come in to the institution for shots, particularly for the need of physical and social distancing and avoiding exposures. Particularly for omalizumab, there has been some provision that has been provided for the pandemic to allow a self-administration at home with certain guidelines in place that we can discuss at a later session. So I'd like to finish up by talking about some of the guidelines for referral to an asthma specialist. These, in my mind, include patients who've had a life-threatening asthma exacerbation, such as those who've been in the intensive care unit, potentially intubated for their asthma, patients who, despite appropriate treatment, have not met their goals, patients with atypical presentations who we question the diagnosis of asthma, patients with particular comorbidities such as ABPA or allergic bronchopulmonary aspergillosis or eosinophilic granulomatosis with polyangiitis, patients who you are potentially considering biologic treatment, Patients who require consistently step 4 or higher treatment according to the GINA guidelines. Patients who require 2 or more corticosteroids in 1 year, as well as folks who require hospitalizations for exacerbations. Thank you for listening and for your attention, and we'll open this up for Q&A.
Thank you very much, Dr. Kher. So what are our key takeaways from this lecture?
Yeah, so, basically, I think hopefully what you took home over the last 20 minutes or so was that biologics in patients with severe asthma really serve as a add-on treatment. They're not in lieu of the inhaler therapy or the anti-inflammatory therapy that we have, despite being an appropriate GINA step 4 or 5 treatment. If the patient continues to get into trouble with exacerbations and or symptoms of poor lung function is when we consider the addition of biologics. That's one, it's an add-on treatment. Number two, if a decision is made that a patient should be on a biologic, fortunately for us, we have many, many options. Right now, there are 5 drugs, as you saw, that are FDA approved. Important to note that they're all against type 2 inflammation. We do not have any FDA approved drug at the moment for non-type 2 inflammatory asthma, although there's an exciting pipeline. And many factors, I think the third point I would highlight is that the reason to know the duration of how often you need these shots, the mode of administration, the side effects, and the data behind why, the evidence behind why they're beneficial in patients with asthma, I think is really so that we can educate our patients as we are trying to help them decide or decide together really which of these 5 options that they would benefit from. And I think at the next session, this session was really geared towards the drugs themselves, but at the next session, you'll get a flavor for that shared decision-making visit and sort of what that involves.
Thank you. Do we have any questions or comments from the group? Can you comment on the Xolair inhaler?
Oh, okay. So that's Lisa's question.
Yep, we got it in the chat.
I'm not aware of a Xolair inhaler. Truthfully, Xolair is the trade name for omalizumab. Are you talking about a Xopenex inhaler? The other one that starts with X.
No, maybe. Let's see.
Xopenex is levalbuterol. It's an inhaler. It's a short-acting bronchodilator, and it's typically. I guess people think about it in terms of benefits, that it sort of causes less tachycardia and less side effects compared to albuterol alone. And that's the generic for Xopenex is called levalbuterol, and it's an inhaler. I often find though that it really needs, you got to pull your tooth and nail together through insurance to cover. It is actually quite expensive compared to your good old albuterol.
I must have been mistaken. I thought there was an inhaler version. I've seen people. Okay, thank you.
Let's see. Alice asks, what promising treatments for non-type 2 are in the wings, and will this be covered elsewhere? Yeah. So, truthfully, we don't have any specific FDA-approved treatment for non-type 2. We really don't. And so if it gets to a point where you have a patient who has asthma, you think their phenotype is more non-type 2, or the neutrophilic asthma phenotype we talked about a couple of times ago, I think, maximizing their inhaler therapy and anti-inflammatory that we currently have. The 2 things that I then think about are, one is we talked about briefly here is the bronchothermoplasty. And I have sometimes sent patients for evaluation for that to see if that would be beneficial. That's one. And then, there have been some studies, certainly, which I did not put in here, but the role of azithromycin. So a macrolide as an anti-inflammatory agent in patients who had asthma to cut down exacerbations. There's this Amazes trial, which was, I think, out of Australia a couple of years ago, that showed that it delayed time to the first exacerbation, or spread out the exacerbation, cut down exacerbations of patients with asthma. And they were not necessarily type 2 patients. So I think there is, so I think azithromycin can be considered. Again, I'm talking about long-term azithromycin. This is not like the 5-day azithromycin that we use for like a bronchitis or a pneumonia. I'm talking about, there are various doses that have been studied, but 250 milligrams 3 times a week or every day of the week that can be considered, with the goal for an anti-inflammatory effect in patients who have asthma with frequent exacerbations, to cut down that. I mean, azithromycin, as you know, if you end up using it, you have to monitor the QT interval on an EKG, make sure there are no drug interactions. Patients often need a baseline hearing test, because sometimes long-term it can affect hearing. The patients get hearing loss. And then, in the studies that showed that azithromycin worked, that these patients tended to have more drug-resistant organisms on like nasal swab that they followed up. Like one of the outcomes of the study was that. So certainly when you're on an antibiotic, you got to worry about drug resistance. So yeah, and I think that's why I put up tezepelumab up there, because even though it's not FDA approved, it's still being studied and fast-tracked last year, and I'm hoping that it would give us some ammunition to help patients with non-type 2 asthma, but currently we really don't have anything specific for non-type 2. Has anybody had patients or interacted with patients who may be on these treatments, or have had experience with patients in your practice?
I have one patient on Xolair,
Yeah.
prescribed obviously by pulmonary, not me.
Sure. And do you have any specific comments on what that is, or how the person's doing?
She just started it, so
Okay.
I can't really comment
Yeah.
yet on the benefit, but I haven't gotten pages yet that she's been in the ER, so I'm assuming that's good.
That is a good thing. So omalizumab, typically, which is Xolair, our oldest drug, it was approved, over 15, 18 years ago, and we have a lot of safety data on it, and it works in people who have allergic asthma.
Yeah, if we don't have any other comments for the lecture itself, we'll go into our case presentation. This will be presented by Dr. Kher. Alrighty, go ahead.
Okay, so this is, let's see, a woman born in 1970, so about 40 years old. She came to us with adult onset asthma. She had no symptoms of asthma growing up, but as a teenager, symptoms predominantly cough, productive of phlegm. She has expiratory wheezing intermittently, has symptoms pretty much most days of the week, and wakes up more than one night a week with the symptoms of asthma as well. She does not have much in the way of allergy symptoms. She has had skin testing for allergy and is negative. She uses albuterol, and her symptoms actually improve, as do prednisone or steroid therapy. Typical triggers are upper respiratory infections, such as, say, cold, sinusitis, exercise, secondhand smoke exposure. She's not a smoker, and then strong odors. Currently, she is on albuterol that she uses as needed, and she uses it quite frequently. She's on budesonide formoterol, so that's the inhaled corticosteroid long-acting bronchodilator combination twice a day. Montelukast. She's on a nasal steroid as well as an antihistamine. So, she clearly is on a lot of treatment for her asthma that's targeting her airway inflammation as well as nasal inflammation and bronchodilation. She's tried tiotropium as well as theophylline in the past, and without success, without much help. She uses an inhaler as well. I'm not concerned about adherence issues. She does not have, she has a good inhaler technique. Now, she says she has missed work because of her asthma. She cannot really walk around too much. She gets short of breath and wheezy. She has been hospitalized 3 times in the prior year, as well as had 3 emergency room visits. including a visit to the intensive care unit and need for intubation. So she's had about 6 bursts of steroids in the last year. Her asthma control test is 10. So if you've looked at the, if you, I don't know if you routinely use it in your practice, but it's not a bad idea when you're evaluating your patients with asthma just to have them fill this out while they're sitting, waiting for you, or in the waiting room, or even do it at home. There are some apps that are available that they can even track it. But basically a level or a score less than 20 means that your asthma is not well controlled. And so her 10 is actually pretty bad. She does not smoke, does not vape, no other inhalants. Basically, in terms of occupation, she worked in customer service, I think at one of these departmental stores, but really has not been able to work. She cannot keep a job because she has missed work so many times, they won't let her get back to work. And certainly stress around that has been a big trigger for her asthma. She has no other evidence of respiratory disease, no other family history of asthma, and really her review of systems is nothing much, I think. You go down? Oh, she has some reflux symptoms, okay? And stress, I put that, I said that as a part of her lack of a job. For a reflux disease, she takes pantoprazole 40 milligrams once a day. Notable things on her exam: she is overweight, her BMI is 30. She appears Cushingoid. She has gained tons of weight over the last 2 years. Mainly, she attributes it to all the prednisone she gets. She has auditory auscultatory wheezing bilaterally on expiration. No evidence of clubbing. And then I'm going to keep the labs simple, but her eosinophil count was 650. So this is quite elevated over the upper limit of normal. Her immunoglobulin E is 100. And then she's had some allergy testing, like I noted previously. She had perineal antigens. She was not allergic to dust, or she was negative also for the specific dust mite antigens and penicillium. So really her allergy test was negative. And then if you look at specific other testing, she had pulmonary function tests that showed moderate obstructive defect with bronchodilator response. And then a chest CT was done that really showed bronchial wall thickening, but that's about it. There was no COPD, there was no emphysema, no fibrotic lung disease, no lymphadenopathy. So bronchial wall thickening is, can be seen, a sign of airway inflammation. It totally can be seen in patients with asthma. And there was no other differential diagnosis there. It was pretty compatible with asthma. So the primary question I would pose for this case is, can we discuss what the phenotype is and how, knowing what you know over the last 40 minutes, what can we offer her as a next step in asthma treatment? So can we all agree, let's see, that her asthma is poorly controlled? She's having symptoms every day. She's waking up at night. She has been intubated for asthma. She's had a bunch of prednisone over the last year, right? We can all think about patients in our mind who, similar patients that we've met. And she's clearly struggling. She can't keep up her job because she's so short of breath that she can't lift heavy things. She can't deal with the dust at work. And, any URI triggers her asthma. So, fair to say high healthcare utilization, right? Adult onset in a woman who's overweight, and frequent exacerbations. And her triggers are not necessarily allergies, but a bunch of other stuff, right? So strong smell, non-allergic, exactly. Alice says non-allergic. And Brenda says eosinophilic asthma. Yeah, so if you look at those 3 categories we talked a couple times ago, right? Allergic asthma, eosinophilic asthma, neutrophilic asthma. Those are sort of the better recognized asthma phenotypes. Within allergic asthma, you can have adult onset or child onset. A lot of information in this case that tells us she's not really allergic, right? She doesn't have seasonal allergies. There's no seasonal flavor to it. People can develop allergy as an adult, but she had an allergy test that was negative. Her triggers are typically more infections. So probably not allergic asthma. Eosinophilic asthma, yes, high healthcare utilization, adult onset, and then frequent exacerbations, and certainly can be neutrophilic asthma too because of the, she is triggered by viral infections. But if you look at some of her biomarkers, right, so we check the biomarkers, we check immunoglobulin E and eosinophil count, and the eosinophil count is clearly over 600. So this is a patient with eosinophilic asthma because of the high eosinophil count may potentially benefit from an anti-eosinophilic inflammatory anti-eosinophilic biologic option. Now, interestingly, she also had an immunoglobulin E that was 100. So if you go back to the slides and look at specific criteria for omalizumab, she actually fits the picture there too. She fits the picture for the goal IgEs between 30 and 300, and she is 100. And this is not unusual, right? I think last time somebody asked me, what do you do when both eosinophils and immunoglobulin E is elevated? And there is data that even patients who have eosinophilic asthma and patients who have high IgE or high eosinophils, they may benefit from the anti-eosinophilic treatments. And the same way around, that they may also benefit from an anti-IgE therapy. So I guess the answer to the first question is that this is most likely eosinophilic or type 2 asthma. Does anybody have questions about that? So the next question, so what would we treat her with? And this is a trick question because there is more than one answer.
Brittany in the chat said rosalizumab.
Yep, you could pick rosalizumab. Any other answers? Trust me, pick a drug, you will not be wrong. Okay, so we talked about 5 drugs today. 4 of those 5 drugs, so mepolizumab, rosalizumab, benralizumab, as well as dupilumab, okay? They all can be used for eosinophilic asthma. Omalizumab is in patients who have allergic asthma with high IgE. We determined based on a history, she's not really had much in the way of allergies. So I would say that even though it's a type 2 drug, I wouldn't necessarily recommend omalizumab for this patient because I strongly feel that she doesn't have allergic asthma. She mainly has eosinophilic asthma. So even though her IgE is within level, I'm not getting a flavor from talking to the patient that she has allergies that are driving her symptoms, okay? So in terms of eosinophilic asthma, you can use any of those 4 drugs. They all have been shown to cut down exacerbations. They all have been shown to cut down the need for oral corticosteroids, systemic steroids. They have been shown to cut down symptoms and improve lung function. So you wouldn't be wrong. And basically, if you would pick one of those, really depends on what they want. So the way I often talk to patients is, rosalizumab is IV, the others are all subcutaneous, okay? So if somebody's getting IV drug every month, you got to think about the time that they'll come in. It's not something that can be done at home. So you got to come in, arrange an infusion center visit. They got to have some sort of IV placed every month, or you have to, if they want to get poked, they don't want to get poked every month, you got to think about putting a pig or a port cat or something like that. So for that, it also, a subcutaneous shot is a subcutaneous shot, right? It's like getting your vaccine or something. It takes 5 minutes, but infusion can often take longer between the time of putting the IV in, the infusion time, the recovery time. So it depends if the patient wants to spend an hour or more in the hospital versus just come get your shot and go home. The other 3 are, so rosalizumab is IV, the other 3 are subcutaneous. The duration matters, so how often you get the drug. Mepolizumab is every 4 weeks, and benralizumab is every 4 weeks for the first 3 doses, and then every 8 weeks. In a patient who perhaps lives away from your hospital or your clinic, who doesn't really want to come in every week or every month, that doesn't want to take time off from work every month, every 2 months is an option after the first 3 doses. And then dupilumab is every 2 weeks, but it can be done at home, right? You can start it at home, and so that's another benefit. Obviously, the patient has to be comfortable giving themselves the shots, right? Some people have fear of needles, and we'll specifically talk about handling that situation next time. and so how often you get them is an option, and the patient can pick what they want. Now, I'd like to highlight that both mepolizumab and benralizumab also, since their initial FDA approval, have now been approved. They come in like a pen format that they've actually now been approved for home administration too. So a lot of options, home versus office administration, the duration, the time duration between shots, certainly side effects, and all of this, those things can be considered in the decision making. But you wouldn't, if you had to pick one, you could pick any of these 4 options and you wouldn't be wrong. It really depends on what the patient wants. The one thing that I briefly mentioned in one of the slides early on in the presentation that I really want to highlight again, because I think it doesn't get enough thought often, is what else causes high eosinophil counts, right? So one of the things that causes high eosinophil counts in patients is helminth infection, parasites, which is not a big problem in the United States of America, but there are plenty of countries in the world where it is a problem, right? Parasitic infection. So I think, and even the US, if the patient has visited or spent significant time in a place that they potentially may get a parasite infection, you want to definitely get that history and test them for a parasite, because the way we mount a response to parasitic infection is inflammation, is eosinophils. And if we shut down eosinophils which is what happens when you pick one of the 4 biologics we talked about, the anti-eosinophilic biologics we talked about, you're basically shutting down their ability to fight a parasitic infection, and you can actually get a disseminated parasitic infection in these patients. So I will often, depending on the history, will check a strongyloides antibody. It's not routinely recommended, although if you look, the guideline based on the country that you work in. So like, for example, the Australian guidelines actually recommend checking a strongyloides antibodies before. The disease is not that common in the US, so we don't really routinely check it, but really it's important. We see people from all, ethnicity in different parts of the world. Many of us see them in our clinics, and I think really putting that history in perspective to see whether they've had exposures, right? If somebody's traveled a lot to South America, traveled a lot to Africa or Southeast Asia, are they at risk for those parasites? And do we need to test for those before we shut somebody's eosinophilic inflammation down, hoping to help their asthma? I think is very important.
So,
can I just get follow-up for this patient of mine, the one that I presented?
Yeah, sure. Whatever you'd like to do.
Yeah. So just quickly, this is a woman I saw actually back in about 3 years ago, and we ended up putting her on mepolizumab, or 3 or 4 years ago. Actually, we didn't have dupilumab approved at that time. We didn't have benralizumab approved at that time. And so she did not want the IV version, and so we ended up mepolizumab. And she's been on it for about 3 years now. She has gone 2.5 years without an exacerbation. I just saw her recently in the last couple of months, where she had her first exacerbation in over 2.5 years, which was great. She actually has 2 jobs that she's work, and she's paying a mortgage. So she's absolutely thrilled with how she's doing, and I'm thrilled with how she's doing. And her lung function, has improved a little bit, but she certainly lost some weight because she's able to exercise, and she's able to get on with life.
That's wonderful. We have a question from Brenda.
Yeah. Can a patient have eosinophilia without allergy? If so, what triggers the eosinophil? Yeah, you absolutely can. And it can be a sign of underlying allergic inflammation. Sorry, I take that back. Underlying eosinophilic inflammation, as well as the other reasons why people can get eosinophilia is parasites. Parasitic infection can cause it.
Thank you, Brenda. All right, Dr. Kher, anything else from you?
The only thing I would suggest is, if it gets to a point you're getting into trouble with asthma, frequent exacerbations, I think the 2 things you can check in that patient is a CBC to maybe get your eosinophil count, like a differential, and or you can just directly order a blood eosinophil count and a immunoglobulin E, before you, and if you feel equipped enough to to with this information. And you know, there's a lot more that goes into biologics, such as how do you get the drug, how do you deal with insurance, how do you deal with prior authorization, all of which we're actually going to tackle next time to get you some practical pearls of how to manage these patients. Should you not have access to a specialist, and should you have to do it on your own in clinic? And so this session is more about providing you with the knowledge, but I think we'll get you some more practical aspects, so it's not this overwhelming.
Exactly. That will be the topic for next week, our shared decision making, and then we also discussed managing injectable medications for the last session. So both very important and very exciting topics. Well, thank you very much, Dr. Kher. We'll get right into our polling questions, our post-test. And now for our knowledge questions. Question 1. Which of the following drugs is an IL-4 receptor alpha antagonist? Benralizumab, mepolizumab, omalizumab, dupilumab, or rosalizumab? Question 2. Which of the following is not targeted by the currently approved biologic agents? IL-5, IL-17, IgE, or IL-4? And number 3. Which of the following is not FDA approved in the US for management of severe asthma? Benralizumab, omalizumab, tezepelumab, or rosalizumab? Okay, Dr. Kher, how'd they do?
All right, so let's see, which of the following drugs is an IL-4 receptor antagonist? The answer is actually dupilumab. That is the one that's an anti-IL-4 that then further downstream blocks IL-4 and IL-13. Benralizumab is an anti-IL-5 receptor antagonist. Mepolizumab is an anti-IL-5 antagonist. This is omalizumab is IgE, and then rosalizumab is also IL-5. So it's really dupilumab is the correct answer. Which is not approved, which is not targeted, excellent. It is IL-17 is the one that is not, that's really non-type 2. And we don't have any current biologic agents, like we said, for this. And then which of the following is not FDA approved? Fantastic, it is tezepelumab. Omalizumab is FDA approved, and then rosalizumab is certainly, and benralizumab is. So tezepelumab is that last one I showed you with the graph that shows that it certainly has promise, but has not been approved yet, but maybe soon.
Thank you, Dr. Kher. Just want to say thank you, everyone, for joining us today, and we'll see you next week. Bye, everybody.
Thank you.